as much fun as this all is, we really have to stop meeting this way. But for now, we can just enjoy it. So today, as you can see, we're going to be talking about Kawasaki disease. You also probably have noticed that the order of the talks in the registry series is a bit different from what you see in your syllabus. That's because I'm doing talks that I can actually do without having to make more movies using our system in the cardiac registry, which the audio is still not working. We're trying to get that fixed, and hopefully by next week it will be, and we can make some more movies. But in the meantime, we're just taking talks that I can put together on Zoom like this. So Kawasaki disease, this is not advancing. There we go. Kawasaki disease is an acute vasculitis. We don't know the etiology of this. It predominantly occurs in infancy and childhood, somewhere after 2 or 3 months of age, and somewhere usually before 5 to 6 or 7. This was, of course, first described now 50 years ago, more than 50 years ago, in Japan by Dr. Kawasaki, at least the modern description of it. And we know that now in many countries, this is the most common cause of acquired heart disease, certainly in the United States and Europe and in many other market economy countries. There probably was an initial case reported back a couple hundred years ago, or 100 and some years ago, rather, back in the 19th century. This was of a child, this was in Europe, of a child dying with a febrile exanthem, and at postmortem was noted to have aneurysms of the coronary arteries. We don't know that that's what it was, but it seems likely. And then, of course, the first modern report was in 1967 by Dr. Kawasaki, what he called mucocutaneous lymph node syndrome, which has now become known as Kawasaki disease. This is Dr. Kawasaki. I took this picture some years ago. Actually, Roberta Williams is over here in the picture, but I cropped her out just so we had Dr. Kawasaki. Then the first US cases were presented almost 10 years later in Hawaii by Marion Malish, who was an infectious disease physician there, pediatrician. The incidence or prevalence of the disease varies quite dramatically geographically and probably genetically. In Japan, we see the greatest incidence, followed by Korea, China, Hong Kong. So in Asia, we see the predominance of cases. Then the number of cases decreases as we get into Canada and then New Zealand and then Northern Europe. It's quite low. The United States is pretty close to Canada in this regard, somewhere in here. So you can see that there's quite variation in the incidence or prevalence of this disease depending on where you are in the world. The diagnostic criteria, there's no specific test, of course, for Kawasaki disease. We don't know what the etiology is exactly, but there are diagnostic criteria. It's sort of like the Jones criteria for rheumatic heart disease. This is fever for at least 5 days, and then 4 or of the following: conjunctivitis, mucositis, lymphadenopathy, edema and desquamation of the hands and feet, and then a polymorphous rash, and the exclusion of other etiologies, things like toxic shock syndrome or scarlet fever can look like this, some other infectious diseases. The diagnostic criteria are different if coronary artery aneurysms are present. Here we would say fever plus aneurysms plus any one of the other principal features, even without almost always they're present. But the coronary aneurysms by themselves are pretty much diagnostic or ectasia of the coronary vessels. So this alters the diagnostic criteria. The fever in Kawasaki disease can either be hectic, up and down, or probably more often continuous. It just, kids are febrile, not much you do changes that. It's often not very responsive to antipyretics. And the average duration without any treatment is 12 days. Conjunctivitis is usually non-exudative. It involves, as we'll see, the bulbar conjunctiva, bright red eyes. Uveitis is quite common. More than 3/4 tend to have uveitis when this is looked for. And this is the typical appearance. The bulbar conjunctiva here is injected. There's sparing of the limbus around the cornea. The mucositis that we see is mostly sort of red cracked lips with fissures in the lips, strawberry tongue. You don't really see an exudate or much in the way of discrete lesions. You just see this generalized lips and mucosa, inflammation, cracking, bleeding, and then the strawberry tongue with the papillae standing out like the seeds on the side of a strawberry. And this inflammation is what causes this appearance. Lymphadenopathy is probably the least reliable criterion. It's only present in about half of patients, especially infants. We don't see this. It's usually cervical when it is present. And another characteristic feature, but the edema occurs early, but the desquamation actually occurs a little bit later. The hands and feet become edematous like this. You can see these feet are quite swollen. The toes are swollen. Same thing here with the digits on this left hand. And even back onto the dorsum of the hand itself, we see edema and swelling. And then some days later, toward the defervescence phase, we see peeling and cracking around the nails, loss of the skin on the ends of the digits. Here you can see this patient had probably some thrombosis or something under the nail here, causing this dark discoloration. A rash involves often the flexor surfaces of extremities or the back. Can also be seen in a diaper distribution, as you see here in this little boy. Then there are a number of associated findings. General irritability. These are some of the most irritable, pathetic little things that you ever see with Kawasaki disease. Neurologic findings. There's sometimes meningitis, encephalitis. Sometimes the LP can be positive in these patients. Hepatitis also occurs. And hydrops of the gallbladder is a relatively frequent finding. You can see this on ultrasound when you're doing subxiphoid views in these patients to look for coronary aneurysms. It's useful to look at the gallbladder to see if it is dilated. We see urethritis, sterile pyuria, orchitis, tender testes in boys, coronary aneurysms, of course, and myocarditis. This is present in many patients. Looks like somebody has a chat here. Let's see. Okay, I guess not. Anyway, we can also see articular arthritis, arthralgias in these patients. Laboratory findings are also fairly characteristic. We see leukocytosis and the thrombocytosis, which is quite characteristic of Kawasaki disease in many patients. You can see platelet counts of 700,000-800,000. We've even seen over 1 million in a few patients with Kawasaki disease. And anemia is also relatively frequent. The typical acute phase reactants are elevated. You can see sterile pyuria, proteinuria. The albumin often is low in these patients, and the serum transaminases are often elevated, indicating liver involvement. We don't know the etiology of this, despite 50 years now of looking for an etiologic agent in Kawasaki disease, but there are some clues. From epidemiology, we know that this is seasonal. It occurs mostly in winter and spring, although there are endemic cases throughout the year, but we do see peaks in winter and spring. There are epidemic and endemic cases like other infectious diseases, and it's rare in infants under about 3 months and in adults, suggesting that there may be development of antibodies or lymphocytes, activated lymphocytes that may limit some kind of infectious agent in these other ages. From the clinical course, it's an acute, self-limited inflammatory process like other infectious diseases, but also like some kinds of autoimmune disease. It can mimic a number of infectious diseases: scarlet fever, toxic shock, some other viral infections, and the rickettsial infections like Rocky Mountain spotted fever, for example. It has characteristics of autoimmune disease: the fever, the arthritis, the systemic inflammation, the systemic malaise that goes along with this, that may be initiated by some kind of infectious trigger, although we haven't definitively identified a specific infectious trigger. There may be possibly more than one. And we know that there is genetic susceptibility of this, just like in many other autoimmune diseases that certain genetic findings have been found to predict patients more at risk. The same thing in Kawasaki disease. Population variation in incidence, like we saw earlier with Asian countries having a much higher prevalence of this. It's much more frequent among siblings. This could be because of it's an infectious agent that also gets passed, but it could also indicate a genetic predisposition. Then clues from treatment. We know the treatment that's effective for this is intravenous immune globulin and aspirin. These are very effective at reducing fever, reducing the inflammation, and helping to prevent the development of coronary aneurysms. The intravenous immune globulin contains antibodies against not only infectious agents, but also bacterial toxins and cytokines and other things. And so it may help clear some of these potentially etiologic agents from the blood. There was a superantigen model that had been proposed for this. I don't think this is currently in favor, but basically this is sort of a summary of it, in which there was a stimulating antigen plus a co-antigen, which seems to be necessary for the superantigen model. And this activates a very large number of T lymphocytes. Most of the time, these would undergo apoptosis, but because of the co-antigen here, the co-stimulant, these don't undergo apoptosis. So we end up with a very large number of activated T lymphocytes that then can interact with innate receptors, the toll-like receptors, which seem to be concentrated on coronary arteries and other small muscular arteries that we see involved in this. And this leads to expression of TNF-alpha, of interferon gamma, and this results in expression of matrix metalloproteinases, which then can lead to disruption of cell walls and of vascular walls and aneurysms. As I say, this is sort of fallen out of favor, but this is based on a mouse model that uses a bacterial antigen injected into the abdominal cavity as a model for Kawasaki disease, a way to initiate a Kawasaki disease-like picture in the mouse model. But I think this has sort of fallen out of favor. We know there is significant genetic predisposition to this. There are a number of genes with particular single nucleotide polymorphisms that are associated with increased risk. Inositol triphosphate kinase here is one of these. This works in the pathway that activates T lymphocytes, the IP3 calcium. This is a nuclear factor of activated T lymphocytes in that pathway. And this seems to be important for activation of T cells, and that may be why this particular haplotype is associated with a predisposition to aneurysms and development of Kawasaki disease in the first place. Also, caspase-3 variants have been associated with an increased predisposition for aneurysms and Kawasaki disease. This is involved in apoptosis and may go back to the superantigen model that we talked about before, that maybe it's less efficient at causing the activated T lymphocytes to undergo apoptosis and therefore allowing more of them to be available. Turns out there are a lot of genes that have been identified as potential risk factors for Kawasaki disease, and most of them involve inflammatory pathways. Other issues that have come up include environmental factors. This is a record of, in blue here is the wind currents that come across the Gobi Desert, across Japan, across the Pacific, and to California. And you can see the correspondence between the increase in wind velocity and increase in the incidence of Kawasaki, the seasonal variation that we see in Kawasaki disease. Here, this is in Japan, this is in San Diego, and this is in Hawaii. And if we look at the map, you can see how these wind currents that would come across Asia and then across Japan, the Hawaiian Islands out here, and then to the southern part of California here. It's thought that perhaps the wind currents are carrying some antigen that may be important for initiating the Kawasaki syndrome. So there seems to be some kind of complex interplay here that we really don't understand yet, just beginning to get handles on some of the parts. Of a genetic background, we know that there are a number of genes, as we said, that predispose to development of Kawasaki disease and coronary aneurysms. And then probably there's some kind of infectious or environmental trigger, either bacterial, or fungus, or virus, or some possibly various agents can initiate this response in genetically predisposed individuals, or maybe even something climatic like the wind currents that we were talking about before. And then there's an interaction between innate immune response, things like the toll-like receptors that are part, or complement fixation, which is part of the innate immune response, and then also adaptive response. IgA seems to be important for this. Of course, lymphocytes, activated lymphocytes, and some interaction here between these two parts of our immune system can lead to tissue damage, vasculitis, and the coronary aneurysms. This probably involves immune complex deposition, a myofibroblast response. Myofibroblasts are a type of smooth muscle derivative that are both secretory cells and proliferative cells. And we'll see that they play an important role in this in a little bit. And then matrix metalloproteinases, which are important for dissolution of vascular walls, leading to aneurysm formation. So we see this inflammation in arteries, mostly that are in transition from elastic to muscular. They're branches of the aorta, which is elastic, going to muscular arteries. The coronaries, the iliacs, axillaries, mesenterics can all be involved in this. And the pathology that we see really is a transmural disruption of vessels by lytic enzymes, particularly lytic enzymes from neutrophils, matrix metalloproteinases that are expressed maybe by the myofibroblasts or by native tissue cells, fibroblasts in the area. And then these lead to initially, usually ectasia or dilatation of the coronaries, and then aneurysm formation. And here you can see the vasculitis. These are little round cells here that are blue, or lymphocytes, and there's some neutrophils in here as well on the endothelial side of this coronary vessel, causing inflammation. We can see that there are activated lymphocytes here out in the wall of the vessel. This is the lumen with thrombus in it here, and then there are activated lymphocytes out here in the wall. And what happens is that the lymphocytes and neutrophils, matrix metalloproteinases all break down the wall. Here you can see the elastic lamina just sort of going off to never, never land here. You can see it's intact up here in this part. This is smooth muscle. This is the wall of the coronary vessel. And here it's dissolved away. This is a grumous material out here from the action of the lytic enzymes from these very active cells. This is a gross picture of a giant aneurysm. Here, this is the coronary, the proximal anterior descending as it's going back toward the bifurcation. And that's approximately the normal size of the vessel here. And you can see this is a giant aneurysm here. This is the distal end of it. Part of it's been taken for histology here in the middle. But this is a giant aneurysm that was about 12 or 13 millimeters in diameter. This was a 1-year-old infant. And you can see inside where thrombus had been adherent to this vessel. This patient died of acute myocardial infarction. This is another aneurysm in a patient who had Kawasaki disease and then died from other causes, not the Kawasaki disease. And so this is an example of a healed fusiform aneurysm. You can see the normal anterior descending up here and the more normal anterior descending distal. And then look at this segment in here that's a little bit dilated. It's not very dilated. It's a few millimeters, but it's bigger than the native vessel. But the main thing to notice is this shiny, glistening white surface here. This is fibrosis. This is the response that we see to dilatation of coronary arteries and the inflammatory process. So you can see this is not a normal vessel. It doesn't react and respond normally like the vessel up here. These are perforators. You can see these are septal perforators that are going down into the septum, and some of them are involved in this process as well. So the coronary abnormalities that we see are ectasia, often as a first step, and sometimes it's the only abnormality that we see, and then aneurysm formation. This occurs in somewhere between 15 and 25% of patients if untreated. This typically develops in the 2nd to the 4th week of the disease because it takes some time for the inflammatory process, the cells to be there to express the lytic enzymes and actually break down the walls of the vessels. So we don't see this in the 1st week. We begin to see it in the 2nd and 3rd weeks most commonly. Coronary abnormalities are more common in younger patients, and obviously the more severe the inflammation, the worse the response to immune globulin. Here you can see examples of coronary aneurysms by angiography here with more distal, relatively normal vessels, but marked dilatation proximally. We can also see myocarditis in half to 2/3 of patients. There's myocardial inflammation, and this responds very rapidly to IVIG. About half of patients normalize right away within the first day. And the improvement correlates with resolution of the inflammatory symptoms, fever, and other inflammatory markers. The histology of the myocardium during the acute illnesses, this is largely data from Japan of patients who died acutely with the initial episode of Kawasaki disease. You can see a cellular infiltrate in the myocardium, just like in any other kind of myocarditis. And then on late follow-up, this is an interesting thing that happened. They did RV biopsies in 200 patients 2 months to 11 years after the acute Kawasaki disease. I don't know that we would get that through our IRB here. Anyway, they found some evidence of fibrosis, occasional fiber disarray, and some myocyte hypertrophy, suggesting that maybe there had been loss of myocytes and then hypertrophy of the remaining ones. This occurred in a small proportion of patients. It certainly wasn't seen in most of the patients that were examined. Treatment, of course, is immune globulin, IVIG, 2 grams per kilo over some period of time, usually up to 12 hours for the infusion, and moderate to high dose aspirin until patients defervesce. There have been trials of steroids, particularly prednisolone, infliximab, and some other anti-inflammatory um, agents, but the benefits of this are not clear, and I think the current recommendations are that these might be useful in patients who have a recurrence or who don't respond initially to the standard treatment with IVIG and aspirin. But I don't think this is part of the standard regimen for most otherwise uncomplicated Kawasaki disease. And then long-term treatment um, with particularly patients who have had or have aneurysms, patients who have not had coronary abnormalities after the initial episode, we've generally not treated them long term. But anyone who has had coronary abnormalities or particularly ones who continue to have coronary aneurysms usually are treated with 2 antiplatelet drugs as well as something like Coumadin or some other real anticoagulant. One of the newer types of anticoagulants are used in this. The efficacy of treatment, there are a number of articles. A meta-analysis showed that there was a significantly lower incidence of aneurysms in the high-dose IVIG group, and there was no significant effect of high or low-dose aspirin on the incidence of aneurysm. So if you just compared aspirin to a low dose of IVIG, 1 gram per kilo, versus high dose, 2 grams per kilo, you can see that the percent with with aneurysms is much lower in the group with high dose IVIG. This is a fairly old study that Jane Newberger was one of the major investigators for this, she and Jane Burns. The incidence of coronary aneurysms, as we said, untreated is somewhere in the 15 to 25% range, but with treatment with IVIG, it's under 5%, usually 3-4%. Some of the risk factors include being a boy. Boys tend to have more aneurysms than girls. Very young children or children over 5 or 6 years of age tend to have a higher risk for aneurysms. Persistence of fever even after IVIG, that is failure of IVIG therapy, and certain laboratory values. Interestingly, a low platelet count is a risk factor for aneurysms, and of course all of the other factors that we know of that occur in Kawasaki disease. The natural history of aneurysms, ectasia aneurysms usually appear somewhere after 7 days, as we said. The peak vessel diameter is usually around a month, can be a little bit less than that. And then if there is regression, we usually see it by 1 to 2 years, and this occurs in roughly half of aneurysms, excluding giant aneurysms, which almost never regress. So this is an example. Actually, it's labeled aneurysm. It really should be labeled ectasia. This is an ectatic left coronary anterior descending circumflex here. This is the anterior descending, and you can see it's just bigger than normal. It's uniformly dilated. So this is ectasia. Here's the right. This is a conus or preventricular branch up here, and you can see it's just uniformly dilated. There's no clear aneurysm. It's just a dilated coronary. So this is ectasia. And then we can see aneurysm formation. Here you can see this is a relatively normal size of the left main. Back here you can see it with color there. And then you see dilation of the coronaries out here at the bifurcation of both the proximal anterior descending and the very proximal part of the circumflex are dilated here. So this is a sort of a fusiform aneurysm. And not only coronaries, but this is an axillary artery. This is the shoulder joint up here, scapula up there. And here you can see this axillary artery has a very long aneurysm in it, probably with some thrombus in the aneurysm. The natural history of aneurysms, the prognosis is better if the aneurysm is smaller, obviously. If the patient is under a year of age, there tends to be more healing of the aneurysm. Saccular aneurysms seem to resolve better than fusiform, and a more distal location seems to be better prognosis. Proximal aneurysms are less likely. to resolve. We don't really understand the mechanism of IVIG, but it certainly can decrease activated lymphocytes, increase suppressor cells, decreases interleukins, adhesion molecules, other cytokines, particularly things like TNF alpha, gamma interferon can be reduced by infusion of IVIG. These things are also seem to be related to the myocardial myocarditis that we see in the diminished ventricular function that we see in some of these. And IVIG also decreases the production and release of other cytokines. Aneurysms tend to resolve by myointimal proliferation or by organization and recanalization of the thrombus if the thrombus is present. So this results in fibrous myointimal thickening, like you can see over here. This is the vessel wall down here. This is where the aneurysm was here, and this is this myofibril proliferation here in the intima, causing thickening of the intima and sort of filling in the aneurysm, if you will. This is a very nice summary from a more recent publication. So here's the vessel, the native vessel. There can be no change at all, or we can see the ectasia and dilatation, which usually then resolves back to a normal coronary size, or we can see the arteritis, necrotizing arteritis, and development of aneurysm formation. The aneurysms themselves can then undergo thrombosis, which usually leads to myocardial infarction. This can be recanalized to form a vessel lumen in here, and then the wall is by fibrosis of the thrombus here, making a fibrous wall. Or if there's no thrombosis, this aneurysm can sort of fill in by myofibroblastic proliferation here, causing a myointimal proliferation, which sort of can level out the vessel, making the vessel lumen look pretty normal, but the walls are obviously very abnormal at this point. This can then calcify. We can see development of stenosis as the proliferation continues. And so you get stenoses, particularly at the ends of the aneurysms. You can get calcification in the aneurysm itself, and this can lead to ischemic heart disease. We know that the coronary arteries don't react normally. This was a study done in Japan some years ago where we have vascular reactivity to isosorbide dinitrate. And this was normal people who had Kawasaki disease but never had coronary involvement, at least by echo. And then ones who had early regression, late regression, and continued to have aneurysms of their coronary arteries. And you can see that the reactivity to isosorbide dinitrate decreases with the level of coronary involvement. Giant aneurysms, the incidence without treatment was about 5%. Now with treatment, it's less than 1%. Very few of these regress. Most of them continue to stenosis and occlusion. These are the patients who are at highest risk for myocardial infarction, and giant aneurysms are associated with most of the deaths from Kawasaki disease. This is an example of a giant aneurysm. Here you can see this is the left main and anterior descending here, and you can see swirling in stagnant flow of blood in this coronary. This is a giant aneurysm. This is about a centimeter or 12 millimeters across. This is another example. Here you can see the aneurysm over here. There's some thrombus that's formed up here, and this is the part that's still liquid down here, although again there's smoke in the aneurysm. This is another example of a giant aneurysm on the right. You can see there's thrombus here in this edge of the aneurysm. This part is open. This is another giant of the right. Here you can see thrombus all around this. There's a little bit of lumen in the middle. This was a teenage boy who had Kawasaki disease. This is a tricuspid valve down here, by the way, who had Kawasaki disease and was fully anticoagulated at this time, but came in with an acute coronary syndrome and had this finding. got revascularized. This is a CT in a patient with a giant aneurysm here that just ends at this point. The anterior descending ends here. Here's a diagonal branch, and you can see that there's occlusion at the distal end. The distal anterior descending isn't seen. Here's the right, which looks pretty normal in this patient. You can also see calcification. Here you see calcium on a CT scan. Here you can see a rim of calcium around this a bit dilated coronary here, and this is the calcium in the aneurysm. There's undoubtedly myofibroblastic proliferation in this area with calcification around the edges and a thickened wall in the middle. The lumen is only minimally dilated, but you can tell from this that the wall is really quite abnormal. So what can happen in patients is there can be no detectable abnormalities. And in those patients, we really see little or no late clinical manifestations, normal cardiorespiratory fitness, and incidental autopsies may show minimal intimal thickening or fibrosis, but really not too much. These are patients dying for other reasons. We know that there can be generalized endothelial dysfunction even for some weeks after the acute episode. Dave Fulton published this. Also that there's abnormal lipid metabolism for sometimes up to years with a low HDL and high triglycerides in many patients after Kawasaki disease. The principal cause of death in the few patients who do die with Kawasaki disease is myocardial infarction. Most of these occur early after the acute syndrome, and almost all within the first year. There, in the past at least, has been about almost a quarter mortality with the first myocardial infarction, in part because these are often very young children and it's very hard to recognize what's going on. About 16% can have a second infarction, and there the mortality rate's even higher, and even higher likelihood of having a third myocardial infarction in survivors. So here's an example of a thrombosed aneurysm in this patient. Here you can see in histology the thrombus is adherent to the vessel wall here, essentially occluding the lumen, causing an acute coronary syndrome. A third of the patients who have myocardial infarctions are not recognized ante-mortem, or at least this was so in the past. I suspect we may do a little better job of recognizing it today. And as I say, this is in part because these are very young children. It's very hard for them to tell us about their symptoms. It may be abdominal pain, maybe vomiting. We may think this is just some other kind of syndrome that patients have. And at least in other studies, almost 2/3 of myocardial infarctions and death occur during sleep, and some with exercise, but this tends to be later in the course of the disease. The indications for surgical treatment: progressive stenosis in patients who have viable myocardium in the distal vessel territory, and no distal lesions, so that it's possible to put a graft in that will be functional into the distal vessel. The results for IMA, internal mammary artery bypass grafts, is nearly 100% one-year patency. These are Japanese data where most of the experience is, and this seems to grow along with the patient. Saphenous vein grafts have a much worse patency rate, just like in adult patients, and are used much less. Revascularization can certainly lead to improved exercise capacity and improvement in left ventricular function. So in summary, this is a severe inflammatory disease very often. These patients can be really quite ill from this. Some of the sequelae that are quite serious, coronary aneurysms, particularly giant aneurysms, can be preventable by recognizing and diagnosing the disease relatively in a timely fashion, and then early treatment with IVIG, which seems to be the most effective therapy. Echo is certainly the method of choice for making the diagnosis, for detecting coronary aneurysms, and for routine coronary evaluation and LV function assessment. Patients who are known to have coronary abnormalities, particularly ones with persistent aneurysms, then angiography or CT is probably the test of choice for following these patients to look for stenosis and development and progression of the coronary artery abnormality. Echo is not particularly good for this, while it is good for detecting the acute problems. Long-term treatment is essential, and long-term follow-up of these patients is extremely important because there can be progression even quite late after the acute illness. Patients who have aneurysms and particularly giant aneurysms require very close follow-up and continued therapy for, as far as we know, for life. So that's a summary and a look at some of the findings that we see in Kawasaki disease. This, I think, is being recorded, so it should be available for later viewing as well. I think we'll